I'm Rong here from UMMC. I'm gonna share about this which antiviral or monoclonal antibody to prevent hospitalization for the high risk COVID patients. Um, okay, so for the outline, I'm gonna talk about mainly the antiviral and anti-SARS-CoV-2 monoclonal antibody. For the antiviral treatment, there are two novel antivirals. One is molnupiravir, which we're gonna talk about this move out trial. As for the Pfizer, that one is a Merck product. As for the Pfizer product, is nirmatrelvir or ritonavir. This is also studied in EPIC-HR trial. It's a Pfizer product. As for the monoclonal antibody, there are three that we already know already. It's bamlanivimab, atezolizumab, followed by casirivimab, indirivimab, and sotrovimab. The novel monoclonal antibody would be a product from AstraZeneca known as AZD7442. The name is tixagevimab and silgevimab. And also, we're just going to explore the various methods for all these maps. Okay. So a heart situation would be if we were to achieve 100% vaccination rates, let's say, who would be at risk of COVID-19 hospitalization and death? So the one that at risk would be immune status, whereby they are immunocompromised from disease or drugs. All those immunosenescence populations are elderly. Next, the age group matters as well. And finally, the comorbidities like obesity, diabetes, and end-stage renal failure. So is there a strategy to mitigate the risk? Looks like there is. We can approach from pre-exposure prophylaxis or post-exposure prophylaxis. Next, we could also think about outpatient and early treatment to prevent the progression of disease. And for the options, we have antiviral, molnupiravir or nirmatrelvir, and monoclonal antibodies, whereby we can approach from pre-exposure prophylaxis, treatment, and post-exposure prophylaxis. So let's talk about antiviral option first. There are two small molecules inhibitors of SARS-CoV-2 replication. So briefly, the mode of action for these two would be for Paxlovid, also known as the Pfizer product, the nirmatrelvir. It inhibits the viral protease that creates other proteins that are needed by the virus in the subsequent step after step 3, while the molnupiravir, it binds to the RDRP part of the virus. It will cause mutations onto the virus and render the virus to be non-infectious and unable to replicate further. So I will talk about molnupiravir first. It is a small molecule. It is a prodrug of NHC, N-hydroxycytidine, which has activity against the SARS-CoV-2 and other RNA virus, and they have a high barrier to develop resistance. The good thing is that it's already administered. The end product is viral error catastrophe. And with that, it results in accumulation of multiple low-frequency mutations associated with loss of viral activity subsequently. So this is a two-step model. First, it incorporates the RDRP, and after that, causing the mutations. And it's studied in hospitalized patients as well. It's known as move-in trial, but it's already stopped already because from the interim evaluation, it's unlikely to demonstrate any clinical benefit. As for the move-out trial, it is successful. It was published last week in NEJM. And from there, they actually look into non-hospitalized, unvaccinated adult who has mild to moderate COVID-19. All of them should have at least one risk factor to progress to severe disease, such as the comorbidities. The symptom onset should be within 5 days from study randomization, and the dose they are using is 800 milligrams twice per day for 5 days only. And the analysis for full analysis is 716 patients in the molnupiravir group. So the primary endpoint efficacy, they are looking at incidence of hospitalization or death through day 29. And from the population, the median age is 42 years old. About a third of a proportion of them are more than 60 years old. They are overrepresented by this Latin America part. Asia Pacific, they're about 1.3%, represented by Japan, Philippines, and Taiwan. As for the risk factors, most of them are obese, about 3/4 of them. Diabetes, 14.9%, followed by serious heart conditions, CKD, COPD, and active cancers, but those are very small numbers. The symptoms onset, about half of them had more than 3 days, less than 3 days, and they appeared to be active against Delta variant, Mu variant, and Gamma variant, but majority in this result is from Delta variant. So for the outcome, it does show that molnupiravir reduced the risk of hospitalization or death by about 30% as compared to placebo. There are 10 patients, 10 deaths reported, one in the molnupiravir group only. And the rate of drug-related adverse effect were actually comparable between two groups, and they are not really significant, and they're quite safe. So from the time to analysis event, it shows that they are 31% lower in the molnupiravir group. And looking into the details of the forest plot chart, the one that I put a green arrow shows that they are beneficial and favor towards molnupiravir. So those who has a baseline negative SARS-CoV-2 nucleocapsid antibody status would benefit from it. Next would be the group in obesity. Well, the Asian race appeared to be beneficial as well, but the numbers are rather small. And next is the white. All right, so these are the four main groups that looks like it could benefit. However, one thing I just wanted to highlight is on the days of illness here. Well, we do know that we have to give early in the course of disease, but for those, if you give like less than 3 days, it doesn't appear to be significant or protective effect. But if you give more than 3 days, but less than 5 days, it seems like it works. So that's something to think about. Okay. So next would be from the molnupiravir group, they showed improved symptoms by day 5, and the largest difference in symptoms were observed by day 10 and day 15. There's no safety concerns were identified, and the mechanism of action is independent of the mutation in the spike protein. So that's why we could see that it works across different strains of virus. And the potential benefit of molnupiravir for the treatment vaccine breakthrough infection were not evaluated because most of them, they are actually taking those unvaccinated patients. So in conclusion, oral molnupiravir is found to be effective if given within 5 days for the non-hospitalized unvaccinated adult who are at risk to progress to severe disease. The big concern would be the mutation part, but after FDA meeting and the approach, they find that it's not really a problem. It's quite small as long as don't use more than 5 days. And it's actually authorized in UK. They should have at least one or more risk factor to develop severe disease. It is not recommended during pregnancy and breastfeeding. As for women of childbearing age, they should use contraception during the treatment and for 4 days after the last dose. So that's a bit of disappointment if we look at the interim and final analysis. During the interim analysis, it shows that there are 50% reduction in hospitalization or death, but after the final analysis, it's only 31%. So in other words, the placebo group actually improved. So, well, what is the difference between the second group of recruitment? Well, they say that there are a lot of female patients being recruited, whether that is one of the factors. Next, whether the variants are also affecting it, because towards the end of the pandemic, before the onset of Omicron, the Delta variant is the predominant variant. And also with the improvement in terms of care and treatment for COVID-19, whether the excess or threshold of hospitalization also affects it. So that's the difference in the interim and final analysis. All right, so in terms of variant of concern, Merck's very confident. They say there shouldn't be any problem because they are working well. It works across all the different strains. And they're also looking at pre-exposure prophylaxis at the moment, so we can await the study. Next, I move on to Paxlovid, which is known as nirmatrelvir and ritonavir. It's a Pfizer product. It's attractive because it's an oral options as well. For this, is bind to the MPRO, the main protease. It's a key step before a high gear replication. So it's that point that they are binding it to make it unable to replicate. It's also studied in their study. It's entering phase 2. I mean, it's already phase 3. Right now, they stopped to recruit the patient after about 75% enrollment already. The primary outcome is proportion of participants with COVID-19 related hospitalization or death of any cause. They are looking at it from day 1 up to day 28. So it's known as EPIC-HR trial. Right, the inclusion criteria again is the same. They have to be within 5 days of symptom onset, at least one specific COVID-19 signs and symptoms, and at least one risk factors that is associated with increased risk of severe disease. And fertile patient must agree to use high effective method of contraception. So for the high risk group, it's defined in the press release. There are 2 groups of them. One is unvaccinated adult who were at standard risk, meaning the standard risk is like those without any risk factors, but they are low risk of hospitalization or death. The other high risk would be vaccinated adult, but at high risk to progress to severe disease. This is the one that who has comorbids. So this is a press release last week, just before the monopiravir group. For that, from the final analysis, they say that the high-risk patient enrolled into the EPIC-HR study, they studied about 2,000 over patients with a confirmed result, says that reduce the risk of hospitalization or death. If you give earlier, within 3 days, you could reduce the risk by up to 89%. But you give still within 5 days, you can reduce up to 88% as compared to placebo. And there's no death in the Paxlovid group. So this is just a table to show that there are difference between this neutronamil and placebo. If given within 3 days of illness, the reduction is up to 89% and it is significant. There are no death in the nirmatrelvir group. If it's within 5 days, it's also significant with 88% reduction, and there is no death in the nirmatrelvir group as well. So in terms of variant of concern, again, Pfizer company is also very confident that it can act on the current strain that is predominant in Europe and US. This is the Omicron, because they say it could act intracellularly on the protease of the SARS-CoV-2. That's their mechanism of action. So it can act on any of the variants. All right, and they're also doing some assays over there. They say that it can possibly inhibit the protease in the Omicron variant, but they are doing their study, so probably we could have some idea later on. And they're also studying the post-exposure prophylaxis among the household members. The trial is still ongoing. All right, but just in a bit of this ritonavir, because many of us are quite familiar with it in our RVD treatment, HIV treatment. So this has quite a number of drug-drug interaction, but one of it is it may interact with the dexamethasone, whereby increase the level. The other thing is the GIT side effect from ritonavir, but GIT side effect could also be seen in COVID-19. So probably there's a bit of things to think about if we were to consider this. And looking at the final result, the Pfizer one, it is consistent between interim and the final analysis as opposed to the Merck's products. Yeah. So then I move on to the monoclonal antibody part. The idea is that it's a monoclonal antibody. It binds to the target of the virus, the spike protein, and once it attaches, it makes the virus become harmless, preventing it to attach to the ACE inhibitors in our body cells. The other rationale of it is that, well, if patient has a delayed production of neutralizing antibodies, it correlates with fatal COVID-19. So perhaps providing passive immunity through antibody treatment could possibly improve the clinical outcome. And we can see that these monoclonal antibodies are rather expensive, so they are mainly segregated in the Europe, US, Asia Pacific not too bad, they're around 16%, but we can see the inequity of distribution if it's in other parts of the world. And what is the consideration to give maps? Well, the timeline is very important. Again, should give as early as we can. And also the circulating variants, because some of the maps may not work against different variants. If we look into how we can approach this, there are two ways. If we are talking about prophylaxis, we can think about pre and post-exposure prophylaxis for the different brands of map. What about treatment? Either we could consider preemptive, early or late, but most of the studies are concentrating in the early disease. The late disease, some of them are still underway. So in terms of treatment, when we talk about treatment and clinical outcomes, the priority would be the high-risk group like the immunosuppressed, elderly, those with any of the comorbidities. And it should be less than 10 days of illness. So in summary, for all the types of maps that is available right now and being approved at different level, the bamlanivimab, atezolizumab, and casirivimab in the civilimab group, it reduced the hospitalization by 70%. So Truimab has a higher chance of it reduced up to 85%. So these top three, we are quite familiar with it, and it has been in the market for quite some time. The new one will be amubarvimab and romlusevimab, reduced by 78%. This is mainly approved in China and Hong Kong. Next is a AstraZeneca product. It's given as IM 600 milligram, known as tixagevimab and silgevimab. So if we give less than 7 days of illness, the reduction is 50%. But we give earlier up to 3 days, up to less than 3 days, the reduction is by 88%. So the earlier that we give, the more benefit of reduction of hospitalization could be observed. Next is a Recdanvimab. This is mainly approved in South Korea. It reduced the risk by 72%. So for the novel mAb, known as Evusheld, from the AstraZeneca, also known as Tisagenvimab and Stilgevimab. The special thing about this is that both these products, AZD8895 and AZD1061, they bind to distinct non-overlapping epitopes of the spike proteins of the receptor binding drugs to the ACE2 inhibitors. And the other thing is that there's a modified FC portion of the immunoglobulin. So the half-life is long, it's up to 6 to 12 months. For the top 3 common mAbs, the bamlanivimab, casirivimab, and sotrovimab, their half-life is like probably as long as like 50 days only. Some are even shorter. So this is something special, that the half-life is very long, up to 6 months to 12 months. So when we talk about the treatment, all right, the dose is 600 milligram IM. For the inclusion criteria, the select those more than 18 years old with lab-confirmed SARS-CoV-2 infection, either by antigen or PCR test, and they should have one or more COVID-19 symptoms. And the primary endpoint is looking at the death of any cause throughout day 29. So with this, we can see that this is the time frame from the symptom onset. If you give less than three or less than 3 days, the reduction is up to 88% as compared to placebo. But if it's less than 7 days, it's about 50.5%. So with each additional day from symptom onset, the efficacy decreases on average by about 10%. So the earlier that we give, the more benefit that we can see. So what about the variance? Does the variance influence on the choice of mAbs that we need to think about or we need to buy? Yes, it does, all right? So during the early phase of pandemic, when the gamma variant is the predominant one, the bamlanivimab, this part, is not so useful. So at that point of time, bamlanivimab is not licensed to be given. So that time, mainly people are talking about casirivimab and sotrovimab. But when the Delta variant predominates, bamlanivimab get the approval. So it's the same for the casirivimab and the sotrovimab, because they can act on it. But with this Omicron virus, the bamlanivimab and casirivimab has no role because they have a marked reduction in the in vitro susceptibility. So then sotrovimab gained the popularity. In fact, I think 2 days ago, US has stopped licensing for that for the Omicron variant. As for the novel mAb, Evusheld, yes, the drug company says that they can act against Omicron virus because they generate the pseudovirus testing in the lab. Although they notice some reduction in the neutralization activity, but the antibody levels will remain the same after that as compared to those who recovered from COVID-19 with a natural born antibody response. So with this, they felt that they can act against Omicron variant, but they are doing further analysis, so we can wait for that news later or findings later. What about data for post-exposure prophylaxis? So post-exposure prophylaxis, most of the study looking at those who are within 6 feet or more than 15 minutes of exposure, those who are providing care at home, direct contact, exposed to respiratory droplets of infected patients. For bamlanivimab, this is mainly studied in a nursing home. They noticed there is about 80% prevention as compared to placebo. And even the residents who have become infected, they are likely to have a low viral load and they can clear the virus more quickly. For casirivimab, region cough, it reduced the risk by 81% as compared to placebo group. And again, the same thing among the infected participants, there are shorter duration of symptoms and shorter duration of high viral load. For this post-exposure in the region cough, it's actually studied among household exposure as opposed to bamlanivimab in the nursing home. What about storm chaser trial? This is by the novel AZD AstraZeneca product. It is actually not significant. After there is no study being published, but from the press release, actually from here they mentioned that they actually include both the PCR positive or negative to study the post-exposure prophylaxis, but they check the antibody before enrolling them, which are negative. So it's a bit different from the first 2 studies. But in short, it is actually not significant for post-exposure prophylaxis. Next, we move on to pre-exposure prophylaxis. So the one that actually licensed, or the one that has the, not really licensed, I mean the one has an evidence is actually the AstraZeneca product known as the proven trial. So they include those who are more than 18 years old, who are at increased risk to inadequate response to vaccination. And during the point of entry, they should have a negative point of care serology test and also negative PCR test. They exclude those who have any prior vaccine or biologic or MAPS for COVID-19, and also those already had confirmed COVID-19 infection, because this is about pre-exposure prophylaxis. So the dose here is actually 300 milligram as opposed to 600 milligram for treatment dose. The route is still the same, it's IM injection. And the endpoint is looking at those who are infected with symptoms and looking at up to about 6 months. So who are the populations in that study? They are mainly those high-risk population, but most of them are in the obese group, as well as more than 60 years old. And with this, we can see that there's a reduction of 83% as compared to placebo. So the efficacy is there. And this is also during for the variant part, this is during the Delta variant. So let's talk about comparison between all the three things that we talk about, mainly about the monoclonal antibodies, the antivirals of molnupiravir and nirmatrelvir. So for the efficacy, for the monoclonal antibodies, it range between 70 to 85%, depending on the brands of the types of MAPs that they are using. As for molnupiravir, the final analysis is 30% efficacy, while the Pfizer product Paxlovid is 88%. For the timing, well, for the oral, it's quite clear that we should give within 5 days of symptom onset. But for the MAPS, the EUA actually said you can give up to 10 days from the symptom onset. But we should be advised to give as soon as possible, because from the Pfizer, from the AZD study, AZD tackle study, the earlier you give, the more reduction or the more efficacious it is. But bear in mind that much clinical trial data actually limit to giving this by less than 5 to 7 days. As for the route of the product administration, oral antiviral, well, it's just orally twice per day. But for the MAP, you could give either IV, subcut, or IM. If you give IV, it's a bit cumbersome because the patient will need to come to then administer the IV medication. You have to go to a center to get it done. Same for subcut, it's just that subcut, they might be a concern of delayed absorption. IM already better than the subcut in terms of PK, pharmacokinetics. All right. Next, on who to give on these three products, well, it's very clear that the high-risk population could receive it during the treatment part. But for the MAP, we can think about those who can't be vaccinated or unable to mount a response in the prophylaxis, in terms of the prophylaxis road. Maybe in my work, especially the novel MAP, that AstraZeneca MAP, because it lasts as long as 6 months. But bear in mind that this does not replace the need for vaccination. It's just an option. But who to avoid? For the MAPs, maybe for those who cannot come to the center for whatever reason, then they cannot receive because someone needs to inject or give it subcut to them. But for molnupiravir, the pregnant lady and woman trying to conceive should be avoided due to the concern of mutations. While for the Pfizer product, Paxlovid, we should bear in mind about drug-drug interaction with ritonavir, so we need to check on that if we're able to prescribe. In terms of cost, the oral medication is definitely lesser than the MAPs. For the Paxlovid, it is about $529 USD. For the molnupiravir, is $700. So for the different parts of MAP, it's in the range of 2,000 if we are talking about treatment, 2,000 USD. I grade the BAM and the test because they are actually not being advised to use already due to the Omicron virus. But the price would be 2,400 USD for BAM. As for CAPS, is about 2,100. Same goes for Sotrovimab, 2,100 USD. But for AstraZeneca product, if we are talking about prophylaxis, the dose is half of it, 300 milligrams. So is the price is 1,200 USD. While if treatment, the full dose is 600 milligram, then the price would be 2,400 USD. Yeah, it's almost my last slide here. So what can we expect in 2020? Well, there are a lot of development. This is an exciting era. Many emerging data is is there for us to talk about outpatient COVID-19, but there is no one size fits all. Okay, I mean, options are there. We have to look into our characteristic of patient carefully. We should select the right patient at the right time and the right strain of virus, something like the antimicrobial stewardship. Next, for the antiviral or the MAPS, the greatest benefit is seen, especially we give at the early course of disease, and also perhaps in the seronegative hospitalized patients. This might be considered, although we are mainly talking about outpatient treatment. And for the MAP, we can use in outpatient treatment for those in mild to moderate COVID-19, and also consider for pre and post exposure prophylaxis. So actually, that's all from me. Yeah, but well, I think that if the cabinet were to purchase, the best option for oral antiviral sounds like it's Pfizer. But it's always good to have another option of molnupiravir, especially for those who can't take Pfizer drugs, like those having a drug-drug interactions or severe GIT side effects. But yeah, the Pfizer one has a bit of more reduction in terms of hospitalization and death of up to 89% if given within 3 days of illness. As for the MAPS, again, it's nice to have all of it. Well, because our country, the main strain right now is Delta variant. We are not sure whether it will be overtaken by Omicron, because if we were to be overtaken by Omicron, the BAM and the CAS will not work well. So then we will need Sotrovimab and the new one, AstraZeneca product. The AstraZeneca product is quite attractive because of the long half-life. So whether it's useful, there's something to consider, because it can be given as pre or post-exposure prophylaxis, and it lasts up to 6 months. So sounds like this is quite attractive, but yeah, this is by no means to replace vaccination. Yeah, really, that's all from me, and yeah, thanks a lot.